Okay, good evening, everyone. My name is Tristan Luke Ali. I'm from one of the house officers at Port of Spain General Department of Surgery. So in our keeping with our theme of topics, I'll be discussing embryology of the spinal cord and the vertebra today. So what do we already know? And let's recap what was discussed prior as well. We know that CNS development commences at the third week of fetal life. Out of the three layers, the one we are mostly concerned about is the ectoderm, which forms the neural plate, and the formation is induced by the notochord and paraxial mesoderm, which will become more important later on in our presentation. And the lateral edges elevate to form the neural folds. So this process of neurulation, I'm sorry, I know embryology is a difficult topic for me, so visual helps me a lot. So I thought I'd include a lot of pictures to help us follow along. Here we can see what we discussed previously in the lateral folding and your neural folds above the neural plate and the eventual formation of your neural tube. Sorry. So the neural folds fuse in the midline to form the neural tube, as we see here prior. This process occurs in both cranial and caudal directions, and the lumen of that neural tube is what communicates with the amniotic cavity. The rostral neuropore, or the cranial opening of this neural tube, closes at the 25th day of life, and depending where you read, the caudal neuropore closes at either day 27 or 28. So this is a visualization of what we just spoke about, showing your cranial and rostral neuropores. If you notice on this slide, you will see the somites, which will become a bit more important later on. We discuss the vertebra. So the spinal cord is formed by the neural tube caudal to the fourth pair of somites. The neuroepithelial cells contain the lateral wall of the neural tube, and the diameter of the neural canal is reduced as we go along in development. And furthermore, the formation of a neuroepithelial layer. So this slide is introduced before. We can see the various parts of development. And I think for those here, you can see at the bottom picture, something that looks a bit familiar to us, showing your horns. Of importance in the top picture, we'll discuss the alar plate, your marginal layer, your mantle layer, and the neuroepithelial layer, how that becomes important. So, sorry, I think this is a bit in the way. All right, so your neuroepithelial cells form neuroblasts, and the mantle layer, which is seen here in blue, is subsequently formed by these neuroblasts. The outermost marginal layer, which we see surrounding the mantle layer, is formed by nerve fibers emerging from the mantle layer. And your mantle layer, so that is what's seen in blue, represents your gray matter, while your marginal layer is your white matter. So this is just a bit more extensive diagram showing a kind of 3D model of what we previously spoke about. So continuous proliferation of neuroblasts form these various thickenings and grooves. So the ventral thickening, as seen on the diagram, is the basal plates containing the ventral motor horn cells. Your dorsal thickening, your alar plates containing your dorsal sensory horn cells. Longitudinal groove between your plates are your sulcus limitans. And the intermediate horn contains neurons of the sympathetic portion of the ANS T1 to L2 or L3. Sorry, I don't know why there's a bit of delay. So once neuroblast formation ceases, neuroepithelial cells differentiate to form glioblasts, and these glioblasts differentiate into astroblasts, subsequently astrocytes, oligodendroblasts, and subsequently oligodendrocytes. Once this production is complete, differentiation into ependymal cells occur, lining the central canal of the spinal cord. So furthermore, we can discuss spinal ganglia, and our motor nerves appear at the fourth week, and these are derived from nerve cells in the basal plate. Just for quick reference, you can see here. The sensory fibers originate in the dorsal root ganglia from neural crest cells. A dorsal primary rami innervates dorsal axial muscle, vertebral joints, and skin of the back. And your ventral primary rami innervates limbs, ventral body wall, and forms major nerve plexuses. We can now discuss nerve cell myelination. So, of course, of interest are the Schwann cells, which originate from our neural crest. They migrate peripherally and wrap around axons to form the myelin sheath. I think we can all visualize that process. And this occurs fourth month of fetal life to the first year postnatal. The nerve fibers of the CNS are myelinated by oligodendrocytes, and the tracts become myelinated at the time of the start of their respective function. So when discussing the spinal cord, we must discuss also the spinal meninges. So the mesenchyme surrounding neural tube condenses to form the dura. The leptomeninges derive from neural crest cells. The fluid spaces within leptomeninges coalesce to form the subarachnoid space, and CSF usually forms during the 5th week of fetal life. This is a quick representation of what we just discussed. So as we could see here, basically the wraparound of these membranes encapsulating that central core. This shows the different positions of the vertebra and spinal cord, A being at 8 weeks, B at 24, C at the time of birth, and D as in a regular adult. So how does the vertebral development occur? So I previously alluded to this picture and told you that the somites were of importance to us later on, so we'll discuss them here. So sclerotomes of somites, they develop from the paraaxial mesoderm, as previously discussed, and this is formed from the differentiation of the intraembryonic mesoderm. The vertebral arch formed from sclerotome around the neural tube, and the body of the vertebra formed from sclerotome around the notochord. The coastal process is also formed from sclerotome in body wall near the neural tube. So around the 4th week, the sclerotomes divide into cranial, which is 2 distinct layers. One is loosely arranged cells, and caudal, which is condensed tissue. The caudal end of each somite fused with the cranial part of consecutive somites around the notochord, and this forms the body of the vertebra or the central. I saw this slide posted, which I thought was good in terms of classifying and solidifying this entire process of chondrification and the formation of the vertebra. So as mentioned before, your body centrum around your notochord, formation of your costal processes and your foramen. And you go through your mesenchymal, chondrification, primary ossification, your fusion, and your secondary ossification. So if you're like me, I really like to see a summary when it comes to embryology because, like I said, without visual, it's very hard to wrap your head around sometimes. So this gives us a good representation and summary of each structure and their origin. So we're going to take a quick peek at it. Of importance here, which we didn't get to mention previously, was the formation of your nucleus pulposus and the annulus fibrosus. So that's from your notochord. So when your notochord disintegrates, you get these structure of the nucleus pulposus, and from your mesoderm, your annulus fibrosus. This also gives us a bit of a timeline in terms of the embryology. So you can see discussed here your germ cell layers, your sclerotomes, ossification, myelination, fusion of your vertebra, etc. And at what age from fetal life straight up until adult life these things occur. So how do we clinically correlate some of the things we just previously discussed? So there are some conditions that are of importance to us that I included. Please feel free to chime in, any of the seniors here, if there's anything that you would like to discuss on it. So spinal dystrophism encompasses spina bifida occulta, which is the congenital absence of the spinous process and variable amounts of lamina. There's no visual of the meninges or neural tissue. Meningocele is a congenital defect in the vertebral arches with cystic distension of meninges but intact neural tissue. And a myelomeningocele, congenital defect in the vertebral arches with cystic dilatation of the meninges and structural or functional abnormal spinal cord or chorda equina. So this is just a quick picture showing us the different types of what we just discussed. So what do we know about myelomeningoceles? So there's a 0.1 to 0.2 incidence of spina bifida with meningocele or myelomeningocele. This has increases with various risk factors, such as a previous birth of myelomeningocele. And if you had 2 or more affected children, this risk also increases to 6 to 8%. There seems to be more maternal than paternal factor here. 65 to 85%, which is very high, as a risk of hydrocephalus, usually before 6 months of life. may have a Chiari-2 malformation. And some of these patients notably can develop a latex allergy, which is a very high amount of 73% from the literature. And this is due to what they say is handling of the afterbirth of the myelomeningocele using gloves that these children may develop later on in life. So what are some important factors to take into consideration in a myelomeningocele? So number one, the size of the defect. Number two, if it's ruptured versus unruptured, and this guides antibiotic therapy. If it's ruptured, they say to cover with antibiotics and can be stopped after the closure is done, or unruptured, where antibiotic therapy is not indicated. The literature says to cover with telfer and sponges soaked in either Ringer's lactate or normal saline to form a sterile ring around the myelomeningocele. The patient should be in Trendelenburg position as to prevent pressure on the myelomeningocele and its contact with any other surface. And surgical closure, unless otherwise indicated, should be done between 24 to 36 hours after birth. So this table basically gives us what we should find on a lower limb or lower extremity exam in a myelomeningocele patient and give us a good classification of what to expect. Now, of course, examining a baby, examining a child at these points may be difficult, but this is what the literature would tell us to follow in terms of what to expect on examination. So again, as previously noted in the table, assessment of the lower extremity neurological function is of utmost importance. A head ultrasound can be done, measure of the occipitofrontal circumference, and to also assess for respiratory symptoms such as monitor for stridor or apnea. In terms of the surgical principles, some of the key concepts are to free the placode from the dura to avoid tethering, which we'll get into a bit later, watertight dural closure, skin closure, to prevent desiccation, to keep the neural tissue moist, use non-latex, as previously mentioned, with the high incidence of latex allergy further on in life. No monopolar cautery and no chemical antimicrobials are to be used on the myelomeningocele. And of course, to get a watertight dural closure, multiple layer closure is advocated for. I know from the textbook, they said on average 5 layers. Some that do 2 layers don't see any complications after, but 5 was the general number that I saw. So this is a picture that was sent. This is actually from one of Mr. Ramnaring's cases of a closure of a myelomeningocele. So we can see on the left the very, very tight watertight closure that was made. So post-operatively, what are some things we need to do? So again, Trendelenburg position is advocated for, a urinary catheter, daily charting of the occipitofrontal circumference, to avoid narcotics in these patients, prevent any form of respiratory distress or respiratory depression. And it also said to do a weekly head ultrasound, patient to be nursed flat to avoid CSF pressure on the incision. Our next topic and clinical correlate will be lipomyeloschisis. So this can be further divided or classified to intradural lipoma, lipomyelomeningocele, which we will further talk about, fibrolipoma of the phylum Terminale as well. So this is a MRI, sagittal MRI, showing a lipomyelomeningocele. So what is it? It's a subcutaneous lipoma. It traverses midline defect in the lumbosacral fascia, vertebral neuroarch, and the dura. Merges with abnormally low tethered cord. It can be terminal, dorsal, or transitional. Dura is dehiscent at the level of the myeloschisis and reflects onto the placode. The lipoma normally traverses this dehiscence and attaches to the dorsal surface of the placode. And this may continue cephalad under intact vertebral arches with possible extension into the central canal superiorly where there is no defect. So how can these patients present? So 56% of patients present with some mass at the back. 32% can present with bladder and urinary dysfunction. And the literature says for early urology consult, but not to delay treatment. 10% can present with clubbing of the feet, paralysis, or lower extremity pain. And some may have other cutaneous stigmata, such as fat pads, port wine stains, and dermal sinus opening. So what are the principles of management of these patients? So first, of course, is untethering of the spinal cord, debulking of the fatty tumor. Surgery is usually indicated on an average of 2 months of life or a time of diagnosis later in life. These statistics show that 19% may improve, 75% unchanged, and 6% may worsen. And the foot deformities, as previously mentioned, may progress regardless. So now we can talk about tethered cord syndrome, as was mentioned in the past, the last two clinical correlates. So this is a low conus medullaris with short, thickened filum terminale, and I made sure to include greater than 2 millimeters because that's what's termed as pathological or an intradural lipoma. It's most common in myelomeningocele patients, but diagnosis clinically in these patients. Clinical factors in MM patients include increasing spasticity, worsening gait, and deteriorating urodynamics. So this is showing us what tethered cord could look like in both a child and adult, and the parameters they use for pain, the foot deformities, as previously mentioned, via lipomyelomeningocele, motor deficits, urological symptoms, cutaneous stigmata, and aggravating factors. So we can see first and foremost with pain, it's uncommon in children, usually the back wheel legs as previously mentioned, but adult tethered cord shows a high incidence of pain. Doesn't see any foot deformities in adults, and in terms of urologic symptoms, they're common in both of them. So that's why they advocate for consult early. So this is just a little representation of a tethered cord on sagittal MRI of the lumbosacral spine. So we can see on our left a filum terminale lipoma, while on the right with spina bifida occulta. So in terms of our management, you can have a lumbosacral laminectomy with division of the filum if only abnormality is a thickened filum. In case of a lipoma, removal with filum once it is separating easily off of the neural tissue. It can recur later years of development, and therefore multiple surgeries may be indicated during massive growth spurts. And in adults, pain relief may occur, but rarely return of bladder function. So another procedure, definitively, such as a urinary diversion or ileal conduit, can be considered. We can now get into split cord malformation, which can be divided into type 1 and type 2. So in type 1, there are two hemicords with their own central canal and pia. They are separate dural tubes separated by an osteocartilaginous septum, absent disc, dorsal hypertrophic bone at the level of the split. You can have some cutaneous manifestations such as nevi, hypertrichosis, lipoma, dimples, or hemangiomas. They are neurogenic high arches. And the treatment of this is to untether the cord as before and removal of the bony septum, dural reconstitution into a single tube. So this is to show type 1 split cord malformation, as you see on both the axial and coronal views. And type 2, there are two hemicords with a single dural tube. It's separated by a fibrous medium septum. Each hemicord has nerve roots arising, and there's usually no spine abnormality at the level of the split, but spinal bifida occulta in the lumbosacral region. And of course, treatment again is to untether the cord at the level of the SBO or at level of the split. Just to tie in lastly with vertebra, I included Klippel-Feil syndrome, which is a congenital fusion of two or more cervical vertebrae. It ranges from fusion of only bodies to fusion of an entire vertebra, both anterior and posterior. Failure of normal segmentation of somites, as we previously discussed in the embryology, between weeks 3 to 8 of fetal life. You can have flattened vertebral bodies, hypoplastic or absent disc spaces, and smaller neural foramina. So this is just a representation, sagittal and coronal, to show you of the anterior and posterior elements in this type of malformation and syndrome. So there is a clinical triad that can present, but is usually in less than 50% of patients, which shows a low posterior hairline, a shortened neck or brevicolus, and limitation of neck motion. There can be other associated factors and symptoms in these patients, such as scoliosis, facial asymmetry, torticollis, Sprengel's deformity, which is a raised scapula, and systemic manifestations such as a unilateral kidney, cardiopulmonary defects, and also deafness. The treatment of this syndrome is fusion of non-fused segment to prevent further loss of mobility. Okay, and that brings me to the end of the presentation. Thank you very much.